right, welcome back to the afternoon session of the first day of our NVAC meeting for September. Our next panel is Immunization Equity, Lessons and Evaluation Approaches. Our presenters will be Stephanie Friedhoff from Brown University, Dr. Ali Muqdad from the University of Washington, Dr. Tara Jatalawi from the Centers for Disease Control and Prevention, and Erin Henry from the Public Health Agency of Canada. And I want to thank all of our presenters. And Stephanie, you are at the podium. You have the floor.
Fantastic. Thank you so much. Thank you for having me. It's great to be here with you this afternoon. I'm going to try to get our blood sugar rerouted to the brain after a wonderful lunch break. So I'm going to talk, I apologize. I'm just navigating technology for a second here. Yes, okay. So we just heard two fantastic presentations from partners in the PAVE program that have really shared with us what it was like to do this work on the ground during the pandemic and what it is like now. I'm going to talk and I'm going to try to frame a little bit, and then we're going to hear from more of our colleagues about how do we evaluate these types of programs? How do we know out of all the things that we're doing what is working and what is not? And how can that inform what we're doing going forward? I'm a member of the Vaccine Equity Group of the National Adult and Influenza Immunization Summit. So the work I'll be presenting is from the entire group. We spent 6 months thinking about exactly these types of questions. And it's really based on what this committee has recommended 3 years ago. I'm sure everybody in the room remembers when we finally saw disaggregated data for hospitalization, severe illness, and mortality from COVID. And we saw, disaggregated by race and ethnicity, and we could see the devastating impact the pandemic had, particularly on communities of color, but other disadvantaged communities too. And there were two specific recommendations. One is the things that we do to try to mitigate and bring more equity to vaccination should be based in evidence. And the second one is we should research so we know what the evidence is. And that's what I'll be speaking to today. So we heard two examples. PAVE was an amazing program. There were so many others. I was personally part in a research and partner in the Equity First Vaccine Initiative, which was funded by Rockefeller. There's, again, so many of us at the time jumped to the challenge, and there was a lot of innovation in the field. This is the report that we put together from the Equity Group. It will be made public soon, and it provides both a summary. We've, amongst the group, discussed some of our lessons learned, but it also has a lot of profiles of these different efforts that we have seen in a way that you can quickly look through. Wait, what was the question they asked? What were their methodologies? How did they study this? And then what were their findings? So we're trying to contribute by summarizing a little bit what has happened and what we're learning from it. So that's what I'll be that's what I'll be sharing and summarizing for us today. If we want to measure vaccine equity, we got to know what vaccine equity is. So we need a definition, and we're going to put forward one for discussion today. We're going to talk a little bit about so what are our tools to measure it? How do we implement those tools? And then what are we learning as we do so? And what does it tell us about what we need to do next? So what is vaccine equity? This definition is vaccine equity is about providing access to and generating demand in long-established vaccines and new vaccines for all populations, with a priority on those populations who need the protection from a given vaccine the most. There's two things in this definition that are really important. One is this is about access and demand. The decision to get vaccinated sits within the individual. The second one is not everybody is impacted by every disease the same way. So vaccine equity is not everybody gets the same vaccine, everybody should get every vaccine. It is about who is most impacted, which also determines our strategies for who should be vaccinated first. And obviously, we've seen this play out in the pandemic a lot when, for example, we had prioritization of elderly populations, which in the early evidence were clearly shown to be more impacted by COVID. But at the same time, communities of color were talking about how often members of those communities don't even reach that age, and due to underlying conditions and pre-existing conditions, need to be considered for priority vaccination. And there's many other examples. So how do we measure vaccine equity? We've just experienced 3 years of innovation in this field, in this research field, and that is really important. We have, and you know, all the details on this slide don't matter. The point of the slide is we've done a lot, and that's important. That's how science works. Apologies. So community-based participatory research is really important, using mixed methods. When we heard earlier from Sam and Christine, you could see some of it is survey-based, some of it is counting the events. There's a lot of different things that we need to think about when we try to measure vaccine equity. In this report that the group has put together, we're trying to organize this a little bit by thinking about measuring outputs. We've done a lot of that in the pandemic. So that includes the number of people who came to a clinic. You just heard a readout from some of these projects that did exactly that. The number of events that were held, the doses administered, social media engagement, number of partnerships developed. So then there's the outcomes. That's what we actually want to measure, but it's a lot harder to do because we want to know, are there actually changes in vaccination rates in the population that we're targeting? We want to know, are there changes in vaccine confidence? And we like to look at times at the comparisons of vaccination rates across specific groups. Now, there's a particular talking point that's important that came from the group that I wanted to share today, which is that these differentials in vaccination rates are important when we look at racial and when we look at those racial and ethnic parameters, but they're not the only way. And that is important because we need to understand other types of discrimination too. So we got a whole set of tools. How do we implement them? What have we learned from how all these practitioners that you're going to hear from and have already heard from have tried in measuring these outputs and outcomes? Effective evaluations of vaccine equity interventions integrate community knowledge. This is a really important part of vaccine equity work. When we talk about vaccine work more broadly, a mass vaccination clinic might be a fantastic way, but it could be a terrible way to actually improve vaccine equity. May's fantastic work on the campaign is a great way to get a lot of people just asking questions, but it's may or may not be a good way to improve vaccine equity. We need that ground level community knowledge in both the intervention design and then in the interpretation of the data. Often the scientists then get the data and walk away to do the interpretation over here. We need to include the people who understand the context in our interpretation of the data. We need to focus on data that fits the purpose. It is very tempting to want to collect a lot of data, but one thing that has consistently come up, and everybody here who's fielded an intervention knows, data collection takes a lot of work. And you're trying to build capacity at the same time with organizations to do this. So let's not reinvent all the wheels and try to be super unique with our data. Let's build on the existing infrastructure. And that's what we heard in the presentation earlier when Sam said, you know, we use the surveillance data from the city of Houston. It's that kind of thing. Building on the resources already in place. Building capacity. These community partners need our help in both understanding how to collect the data, and we need to listen to them when they say, you're telling me I should collect the data this way. I understand we need the data. Let me tell you how we think we can actually better collect the data. We also heard this earlier from Sam. We need to understand that vaccine equity work is fluid and we need to frequently reassess it. That is a challenge for research because you need a clean research design. You can't change this halfway through. And one thing the group discussed is piece your projects. Don't try to bite off the whole piece, right? And we can get more into that in the discussion. So with all these measures and these concerns and what we learned about how to do good evaluation work, what have we learned so far? And obviously there's a lot more learning, so this is a very abbreviated slide. But we do know that effective vaccine equity interventions understand each population of focus and their core challenges and priorities. There's a whole set of tools addressed through that. But if you don't understand the population in a granular level, you cannot serve them. That means you need to work closely with community-based partners that are already serving that population across the spectrum of their needs. Another key important thing from the group is, and this is a sentiment that has been uttered many times, not just recently, really since the early days, we need to move past the vaccine hesitancy-based framework. And here's why. We've had too many interventions that focused exclusively on hesitancy. First, we should skip the word. I've been saying this for 4 years. Confidence. It's about confidence. But it is all behavioral science. It is all what sits within the individual, and it misses the structural parts of this equation. So vaccine equity, as we know, is as much about structural barriers as it is about these individual barriers. And when we heard earlier about this really important work that's going on at the border, that's initial education work. Right? This confidence work that we heard about earlier is really important. And I don't mean to say we shouldn't be doing that. We should be doing all of that. But we also need to think about, and we've heard all of these things before, we need to think about, you know, if I don't have a sick day, if I don't have childcare, where the early talks, there's so many more examples of what stands in the way when people try to access vaccinations. And one core learning from the Equity First Vaccine Initiative was that the community organizations came up with this sentence that they ask people: how does the vaccine fit into your life? That is what we need to be thinking about when we think about vaccine equity. So what is missing and what do we need next? Again, this is about research. So what is missing and what do we need to do next to get a better understanding of how to research this and have better evidence to inform our interventions? Key recommendations from the group are that we need to conduct more granular research. I just mentioned that. Especially because it is incredibly hard to establish that chain of causality. Meaning, I hear an influencer on TikTok talk about something, I might get interested, but from there to my decision to get a vaccine is a really long journey. And there are many, many, many influences on that journey. We need to measure and identify the reinforcing elements. We call this moderating variables. When we count the number of people who came to a vaccination clinic, what were the relationships that were necessary to get them there? This is the key questions that the communities asked us. Stephanie, can you help us measure the trust we've already built? We can count that by people showing up. And what makes that trust work? And how do we show this back, that this is actually work that we're doing every day, but we don't know how to measure it? We need to identify opportunities to braid and blend funding mechanisms. This is essential because, again, these partners that are so essential do all this work, but they do it consistently. And sometimes we come with funding and sometimes they don't have funding, right? So braiding and blending funding is really important for consistency and maintaining relationships. And then we also should be studying the cost effectiveness of what we're doing. Maybe there are things that have, you know, the expensive things and not so expensive things that have the same outcome. We should focus on what makes the most sense. And then we should also put together an archive of supportive materials and evaluation toolkits just to support this field as people are coming together as evaluators of this work. So in summary, we've made amazing progress in these 4 years, and we can't go back to before. We really want to. I wasn't a political reference, I swear. But we want to move forward and on this innovation. We need a systemic review of the literature and available evidence for inclusion in the community guide. The community guide is guards guides funding and applications, and we don't currently have enough robust evidence on what drives vaccine equity interventions or what drives effective vaccine equity interventions. We need more standardization of methodologies, and we need more comparable evidence on what works and for whom. And that's it. Thank you so much.
Thank you, Stephanie. Our next presenter is Dr. Ali Muqdad from the University of Washington.
Thank you. Thank you for having me. And I don't know how can I advance my slides, so I'll say next.
You just say next slide.
Will do. And sorry not to be with you. I had a family emergency, so I can't be in person with you, but thank you for inviting me. Next. I'm presenting on behalf of the Population Health Initiative, and we have done several projects around vaccine equity. And I'm listing them here, but I will focus on the second one, which I've been asked to do, achieving equity in childhood vaccination, which we did a mixed method study in 3 states. And we arranged these states performing at the lower level, medium, and high level, and we picked 3 counties within each state to do so. But there is a lot of work that we are doing around this. Next slide, please. And on purpose, I have made a very long presentation. I'm not going to take a long time, but I put all the information from all the studies that I put in and the studies that are ongoing, what we are trying to do, just for your references, and happy to make these slides available for everybody who wants to. So with the study that I'm talking about, we had 3 aims. We wanted to measure the change in childhood immunization equity over the last 15 years. And we picked the 3 states, strong, weak, and medium. And we wanted to look at qualitative analysis with key informants in each of these states, the 9 counties in these states, and at the state level as well, in order to figure out what was the most effective intervention or public health policy that has improved equity in vaccination. And of course, we wanted to look, since we did this after COVID-19, what's the impact of COVID-19 on whether we had benefit that are transferable or not on immunization equity. Next slide, please. In the quantitative method, we use data from the National Immunization Survey, which is a survey. When I was at CDC, I had the honor to run that survey for a while. We did logistic regression in our analysis to find out who's been fully vaccinated by a lot of variables, adjusting for confounders and interactions. And we did the comparison and the difference of coverage, of course, by race, ethnicity, and income group in order to check the equity. And we used the immunization registry as well to calculate the percentage change in county childhood immunization rate from 2015 to 2020 to see if there is a change, and it varies if there is an equity in that change as well. And we compared the data to COVID-19 vaccination data. Next slide, please. And this is from our publication. This has been published. You could see here fully vaccinated. Again, this is from the National Immunization Survey, 2007 to 2019, pre-COVID-19. And you could see the variation between MMR, hepatitis B, and DTP in terms of vaccination. And this is at the national level for the United States as well, for the United States, not these 3 specific states. Next, please. And then when we did the comparison, again, this is still, we're looking at the national level, and the comparison here, I'll take a moment to explain it. The line is compared to white. So you're looking at Black, Hispanic, and other racial group, and looking at the vaccine, MMR, hepatitis B, DTP, and how the vaccination coverage varies by race compared to white. And you could see here for Hispanic, for example, DTP are much lower than white, others as well. For Black, for example, you see the MMR is the one that's the lowest compared to white. The others, still a little bit lower, but within the confidence interval. And there is a huge variation by race, by specific vaccine as well. Next slide, please. And then you remember when we looked at the 3 states that we picked them at the 3 different levels, we were looking at fully vaccinated. When you look at it by vaccine, there are a lot of variations. So you look at DTP, for example, here, which is Arizona, the lowest, Washington, the middle, North Carolina is the highest. But that changes as when you look at different vaccination. MMR, Arizona is doing way much better than North Carolina and Washington, and above the national average, whereas North Carolina and Washington are below the national level. So the message here, even when you look at vaccination in terms of equity, there are huge variation by the type of vaccine within each state as well, and within, of course, counties within the states. Next slide, please. And here I'm looking at the qualitative study, some of the quotes that we have found, and some of the results are similar to what my colleague just presented. And I'm sorry, I missed the previous presentation, but I've heard from my colleague that they're touching on the same issues that we all are concerned about. So if you look here, for example, far more community, I mean, they don't understand how to navigate the system. And sometimes even if the kids can speak good English, but you cannot count on the kid in order to translate to the parents what's happening because they don't speak English or Spanish. So there is a huge issue here and then limitation when it comes to language barrier. My colleague presented about the role of multi-sectorial partnership, which is we found out in our qualitative study it's very important. So people here, when there is a strong partnership within the community, there is way much better vaccination coverage. And there are so many common barriers, for example, here, people who are working 15 hours, people low income, and they come and you can't talk to them about measles vaccination, how to get your child. And you need to tailor that message for somebody who's working 15 hours, for somebody who's not, for somebody who has the language or not, for somebody who's been part of the community or not. Next slide, please. And we looked at what's really has been going very well in many places in order to improve vaccination or limit vaccination, reduce the vaccination rate. From our qualitative study, the vaccination exemption always came up as one of the main issues that is really not helping the health officials in order to promote vaccination and increase vaccination level in their community. Also, the scope of the medical practice. For example, here I'm putting a quote. In Washington State, there was a willingness for the provider to provide a vaccine irrespective of the insurance. And the state decided, the healthcare authority decided to reimburse. And that made a big difference. The budget, we found out in many places, the budget level also can impede or help. And sometimes funding could help, and the reimbursement, dealing with the reimbursement is a big issue. And in our state in Washington, they were provided the immunization leadership in the state were provided access to the Department of Health, were provided information about the student vaccination, and they found out a lot of information here that helped them address equity and reaching out to people who are not getting their vaccine. Next slide, please. So what we came out from the study, looking at both quantitative and qualitative, putting it together, is really building a trust. And I know my colleague touched on it. And tailor your message basically for the community. And then there is no one message that would fit all community. And involve the community and have them participate in what you are doing, and ensuring their involvement of the community. This will help you to promote vaccination, especially when it comes to minorities. And of course, has to be multi-sectorial. It can't be one group. This is all hands on deck for all of us to work together, health partners, organization, in order to increase vaccination. Next slide, please. What are our recommendations? Here, to my surprise, enhance the data system. I know we talk about this, we have surveys, NIS is one of them. But to my surprise, somebody who ran NIS for a while at CDC, and I ran BRFSS for a longer time, the data coming from CDC didn't match the data we had at the county level. So there was discrepancies for different reasons. I'm a survey methodologist. I'm not going to get into it. Also, we need to promote equitable policy priorities. And many of the data system, and stepping back here, did not require to collect data by race ethnicity. And that has been an issue for us during the study. Engaging the community. And again, my colleague talked about vaccine confidence and then the wording and what we call it. But we had a lot of, unfortunately, social media attacking the vaccine and using COVID-19 as well as a platform. During COVID-19, use a platform in order to attack vaccine. Next slide, please. So my takeaway here is reduce the cost and address the inequities in immunization and racial disparity. With all this effort that we have been doing, and we've been talking about for a long time, we still see a lot of disparities, as I showed you during this presentation. Vaccine attitudes and belief are complex, and we need to address them in the specific community where they are. Also, the point that I don't have here on the slide, which became a very important point during our study. This is a moving target. So by the moment we find out what's happening in the community and we try to address it, these are changing. I mean, the only constant in this is the variance and how it's varying. These attitude change on a regular basis, and we've seen a bigger change during COVID-19. Positive in places, negative in place. Data limitation is a big problem for all of us, and we've seen it in our study. The state and local health agency, by the way, the county, have a big and powerful contribution in order to do this. And there are structural barriers to vaccine that, motivation alone is not going to overcome them. So telling people go and get your vaccine and you convince them to do it, but there are other barriers that we need to address. Next slide, please. COVID-19 lessons. COVID-19 pandemic disturbed everything we do. I mean, this is not something new that we didn't we found, but also we had a hard time during our survey because people working on immunization are sick and tired for people calling them and collect data. So we had to address these issues, and really the COVID-19 highlighted the political commitment. And I know this is a government presentation, but also when politics intervene in science, how bad it could get. And this has happened and became very clear during our qualitative. People told us that sometimes the politics didn't help, but the political commitment helped them a lot. But sometimes when it became political, it didn't help at all. And of course, we need to build the trust in the community and be ready to develop flexible and, again, community-driven solution in order to address these complex challenges. I'm saying I'm done. This is my last slide. Next, please. Thank you. And I have all the slides for all the studies. Thank you.
Thank you very much, Dr. Muqdad. Our next presenter is Dr. Tara Jatlawi from the Centers for Disease Control and Prevention.
Good afternoon. Thank you so much for having me. I'm looking forward to sharing some of the methods and approaches we've used in a very large adult immunization evaluation. And we will be sharing findings at a later time. So we can go to the next slide, please. So first, I'll provide a brief background on this project, then discuss the design and expected products that may be useful for this audience and your partners. And finally, I'll discuss some next steps for dissemination, as well as some updates on CDC's Partnering for Vaccine Equity program and goals for the future. As I mentioned, I won't be discussing results of this evaluation as they're being finalized, and we'll hopefully present those on a future call. Next slide. As many of you know, during the COVID-19 pandemic, CDC leveraged existing partnerships and created new ones to implement vaccination programs or supplement program activities across the country. At the onset of the vaccination program, these partnerships were focused on adult populations, particularly those at high risk for infection. Some were also funded before COVID-19 vaccine rollout, and so activities were first focused on flu vaccination and then included COVID-19 vaccines once they were available. By 2021, we began planning out an evaluation of this adult immunization partnership work. And in 2022, CDC funded NORC to conduct a comprehensive mixed methods evaluation, which will be the focus of my presentation today. Next slide. So I'd first like to discuss the approach and design of the evaluation. Next slide. Our objectives were focused on understanding effective adult immunization uptake strategies, especially for disproportionately affected adult populations, in order to build the evidence base in this space. We expected this evaluation to lay the groundwork for future adult immunization evaluation efforts. Next slide. In setting up the evaluation, NORC used several frameworks to guide the approach. We have CDC's framework for program evaluation in public health to organize the project, and RE-AIM, which has been mentioned, an implementation science framework to guide the conduct of the evaluation. And finally, but critically, they also leaned on the culturally responsive evaluation framework to ensure inclusive and equitable methods, that those were used, allowing space and considerations for things like cultural context, historical trauma, and power hierarchies and systems. Next slide. Both the CDC framework and the culturally responsive framework feature partner engagement as key collaborators in the evaluation. NORC worked with CDC staff to identify the multitude of adult partnerships that were leveraged, and additionally worked with key partners like the Association of Immunization Managers to identify priorities and start planning the evaluation. An evaluation technical assistance group, the ETAG, was created from partners representing community-based organizations, immunization program managers, and public health organizations as some examples to provide critical input and feedback on the planning and execution of the evaluation. And NORC has convened the ETAG multiple times over the course of the project. Next slide. So NORC worked with CDC staff to identify the various adult immunization partnerships and efforts happening across both CDC funded and unfunded partnerships, and to see what data were available to inform the evaluation. This assessment across partnerships and deeper dives into available data comprised the core evaluation. It was recognized that data were limited and additional sub-studies would be needed with primary data collection to assess strategies and networks and look more closely at some large partnerships, including work with the Administration for Community Living, ACL, as well as immunization programs. A separate cost analysis was also planned and is underway, and I'll provide some additional details on these sub-studies in a few moments. Next slide. So I'm going to briefly highlight data that were reviewed for the core evaluation, and again, findings will be shared at a later date. Next slide. So looking through progress report data from almost 500 partners, over 800 reports were reviewed and key elements were abstracted at the start of the evaluation. Data were primarily from jurisdictions' immunization programs, as well as partners within the Partnering for Vaccine Equity program, partners focused on vaccine confidence and demand, and partners serving other disproportionately affected adult populations. And some of the key elements are highlighted here. Next slide. So I'm now going to briefly cover a high-level overview of methods used for the sub-studies, just to give a bit more information on how those were conducted. Next slide. So first, case studies were conducted using a participatory approach involving the ETAG and other partners. NORC collected primary and secondary data to take a closer look at important strategies for the strategy-focused case studies, and then take a closer look at the interrelationships, which is the network-focused case studies, among selected awardees and partners and how they interplayed with one another. NORC has reviewed findings from across studies and identified effective strategies for improving adult immunization. These strategies demonstrated evidence of improving vaccine access, equity, and/or confidence among key populations, and some of these are highlighted on this slide and have also been mentioned in previous talks. Next slide. So next we have the jurisdictional sub-study, which aimed to determine what elements of an adult immunization program are most important and which had the most impact on the COVID-19 vaccination response. This was a collaborative effort with AIM to recruit a sample of jurisdictions, and this led to 12 key informant interviews across 12 awardees. These findings have been compiled and were presented recently at the National Immunization Conference by NORC colleagues. Next slide. The ACL sub-study included a survey designed collaboratively between NORC, CDC's Immunization Services Division, the National Center on Birth Defects and Developmental Disabilities, and ACL. It aimed to assess the effectiveness of the strategies that aging and disability networks implemented to increase vaccination rates and promote equity among older adults and people with disabilities. Next slide. And then finally, the cost analysis sub-study focused on one of 3 pre-selected strategies, which are underlined here at the bottom of the slide, and include interviews to understand the approach for the partner strategy, identify costs associated with implementing the strategy, and lessons learned around cost analysis and data collection for cost analyses in the future. Next slide. So NORC will be presenting findings in a profile format rather than a traditional narrative, and a profile template is shown here. Profiles will be concise, uniform, and simple to help readers quickly identify key information. They will present enough detail for readers to understand the most essential components for replication or future implementation and evaluation. For example, we'll be using the information to consider for future funding opportunities or guidance for our partners. Next slide. So now I'm just going to highlight some next steps. Next slide. I wanted to show this suite of products that NORC will be developing in the next several months with the goal of disseminating findings broadly in various useful formats. We anticipate sharing these with our partners and audience such as that's here today as soon as possible. We're finalizing the findings from the evaluation and working on these dissemination products in the next few months. Next slide. I also wanted to provide some, next steps for some of the work that we do in adult immunization for the future. And I wanted to highlight that the Partnering for Vaccine Equity program, which has been such a fantastic program since 2021, it was aimed to increase COVID-19 and flu vaccine uptake for adults in racial and ethnic minority communities. And it's been recently redefined to address vaccine equity in both children and adults and across multiple priority populations so that we can expand the vaccine equity work that we do. Next slide. We plan to continue to monitor and evaluate funded partner activities to ensure program improvement and to best support our partners. So this adult evaluation and other evaluations are critical to inform the funding opportunities that we develop and make sure that the programs that we're supporting include evidence-based strategies and practices so that we can best serve those communities. Again, we look forward to sharing the final findings from this evaluation with you all as soon as possible. And I think that's the end. The next slide. If you have any questions, my email is here, and this is a huge collaborative effort between NORC, CDC staff led by Isela Medina Martinez, and of course, all the wonderful and fantastic partners that we've worked with over the last few years. Thank you.
Thank you very much, Dr. Jetlawi. Our next presenter is our own Erin Henry from the Public Health Agency of Canada.
Great. Good afternoon, everyone. Thank you for having me. I'm very happy to be here to talk about our Immunization Partnership Fund. So I have to do this with my glasses. Our IPF is the first grants and contribution fund that Canada has had, and it started back in 2016. And it was really when we started the program, it was more focused on childhood vaccines, and it was really focused on mis and disinformation, knowledge, attitudes, and beliefs. And then COVID came along, so we weren't able to evaluate the initial program because we totally pivoted how we used the IPF. And over COVID, we expanded it to a lot more money. So originally it was 25 million over 5 years. But during COVID, we were able to give participants 54 million over 2.5 years. And then in 23 and 24, 9.5, another 9.5 million. So a lot of money. And we really, the program was instrumental in reaching priority populations during COVID-19. But if you look at the original program design, two things have not changed in all the years that we've had our IPF, and that's really the core program principles. So the principles are that funding recipients have to have culturally safe programming, it has to be equity promoting, and it has to be evidence informed. And the other thing that hasn't changed in all of those years is our priority populations. So we have two buckets. We have age and stage, which we look at families and parents and caregivers, women, pregnant people, teens, youth, children, seniors, people with disabilities, people with chronic conditions. And then we have our socio-cultural factors. So Black, Indigenous, racialized communities, linguistic and or religious minority groups, newcomers, 2SLGBTQIA, or housing insecurity, people experiencing substance abuse disorders. So our two priority populations have not changed, nor have the core principles. But when it comes to really looking at what Stephanie talked about earlier, the methods to measure these programs, we've really only have had performance measurement tools because we have not been able to do a proper evaluation. We were supposed to do one in 2021 on the initial program, but then since we pivoted during COVID and we were so busy during COVID, we haven't had time to do a proper evaluation. So mostly what I'll be talking about today are our outputs, but we're really looking forward to the future of how we can measure some of those outcomes and what that's going to look like. So our logic model, which I just had up, we've tweaked that many times over the last number of years as we've tweaked the program. So our evaluators are not going to love us when it comes time to actually measure what we've done. But I just wanted to give you an example, a few examples of the programs that we are funding and some of the great lessons that we learned. So the Dr. Peter Center, this is a great center in downtown Vancouver that provides health services to very marginalized, hard to reach populations. And Dr. Peter Center has been around since 1996, and they have a very good reach across the country. So not just in downtown Vancouver. And so one of the things that we were able to do was when we provided funding to Dr. Peter Center, they were able to do 37 micro grants across the country to community organizations that we ourselves as the federal government are a barrier because it takes a lot of capacity to apply for federal funding. And so when we're trying to reach those really targeted populations and those community organizations that work with them, it's not always easy for them to reach us. And so what we learned during COVID was doing these micro grants, we're able to get a lot more bang for our buck. Also, one of the other programs that we've funded since 2021 is the Alberta International Medical Graduates Association. So AIMGA has done incredible work using internationally trained medical graduates as vaccine navigators. So they're used to promote vaccine initially among newcomers in Calgary. But it was so successful in Calgary that the province actually expanded the program throughout the province. And so they use their medical expertise, but also their cultural fluency to build trust in their communities, and they reduce the language barriers during vaccine services. And at the beginning of COVID, we had our first outbreaks in actually meat processing centers in Alberta, and it was really hard for public health to get in. But once we started working with AIMGA, we were able to get into some very specific targeted populations to do COVID-19 vaccine clinics. And so it's just a great way to show how when you think outside the box, but use the people that you have in your community, how successful we can be. Now, how we measure that is a whole other, that's what we're talking about today. So this is just a bit of a snapshot of what the Immunization Partnership Fund looked like during our 2021 to 2023 years. And one of the things that Susan asked me to talk about is our Northern Wellness Fund. And so in Canada, we have 3 territories that is right beside your Alaska. And so large geographical space, but not very well populated. But we do have a lot of Indigenous communities. So we have Inuit communities and First Nations communities. And of course, we have many federal departments have health programs, and we're always wanting to give them money. But they have very low capacity. So you often have, in the local public health or the territorial health department, a nurse that is the immunization director, she's the STBBI director, she's the TB director, and all of us are trying to give them money, but of course we want them to report back on the money and how they're using it. And it just, it wasn't working. And so our Indigenous Services Canada created a fund called the Northern Wellness Fund. And so all of our different programs in the federal government provide funding to this bucket, and they work with their Indigenous leadership to decide how that money is spent. So they don't have to report back, even though I give them immunization funding, they don't have to report back on their immunization activities. And mind you, we have a very good working relationship with them, so we do know what they're doing in their immunization programs. But it's just another way to decrease barriers for organizations that have capacity issues. So we have lots of project outputs, as Stephanie mentioned earlier. And so this is just a snapshot of what they are. But one of the things that we did start in 2021 was what we call community of practice sessions. So we run about 3 of them a year, and we invite all of the recipients of IPF to come together for either a day or half a day with my program people. And it gives them an opportunity to talk about the project that they're working on to other recipients, so that we can see if there's any that can actually work together and leverage some of the funding that they have. It's a time where we talk about our performance measurement tool with our community recipients, because this is another thing. When we have low capacity, we have some organizations, like obviously our academic organizations that we fund, that are great at using our tools, but other community organizations who, again, you have one person wearing many hats in an organization, and then they have to report back to us, can be very time consuming. So we use those community practice sessions to work through some of those issues. And here is just some outputs from our 23 and 24. Again, one of the things that we have found very successful. Now, of course, this is qualitative data and outputs. We'll get to our outcomes in a little bit, is using what we call community peer ambassadors or vaccine navigators. There's different names that we use, but they really are an important piece of ensuring that we're having cultural safety and cultural care when doing immunization programming or clinics. So I'm just going to talk a little bit about the challenges that we have with performance measurement over the last number of years with this program. And one of them being is because we keep changing the goals and objectives of the program. But that is also, a best practice to ensure that we're using it to the needs of our communities. But when we talk about the tool, when I think back to 2017 and 2018, we were actually using a paper method, which was very time consuming for people to input in, and then very time consuming for my analysts to extract the data. So we have gotten a bit better, and we have automated the tool. We're still looking to improve that as well, though. But we're also setting up times where the recipients can work with my analysts on how to use the tool properly. So we didn't have that set up before. And we just expected people to intuitively understand what we needed them to input into the tool, but actually spending time at the beginning with the recipients as soon as they get their funding to explain and to have that open communication has really enriched the data that we've received. The other thing that was that's going to be difficult because I'm having a meeting with my evaluators soon is, for demographics, we want to ensure that we're providing, low barrier or no barrier services to our hard to reach populations. But if they come to a vaccine clinic and we start asking them a lot of demographic information, that's not going to help with the trust issues that they have. And so we've sacrificed some of those indicators to ensure that the care that people are getting is very low barrier or no barrier. So then it gets difficult when you talk about outcomes on how you ensure that you're reaching the people that you're supposed to reach. The other thing that we've done is develop some infographics to share with our participants, and this is just an example, to start up conversations at our community of practice to ensure that we are building capacity with these organizations. There's some organizations, obviously, that need more capacity building than others. And this is just one of the tools that we use. The other thing that we've learned is that it's really important to have, when you're starting out with a program, to have some evaluation methods built into your G's and C's program, which would have been helpful a few years ago. So if we look at our 2024 to 2026 fund, we have changed the goal again. So right now we've expanded it to all vaccines and all ages. Like I said at the beginning, we were really targeting our childhood vaccines, but now we are really putting an emphasis on the adult vaccines and also considering what has come out recently in the last 2 years, but then also what's in the pipeline. But again, the IPF's core principles of being culturally safe, equity promoting, and evidence informed has not changed. And so if I look about what's happening in the upcoming 2 years, we are working hard to ensure that we have ongoing funding for the program, since we do believe that it is valuable. And since we are going to be doing a formal evaluation, I'm sure that's what's going to come out of it. We are exploring different software options, again, to help recipients with data collection and us with analysis. We're evolving the logic model, as we have every year or every 2 years. Again, starting this year to create those opportunities for our community of practice so we can have some good knowledge, translation, and exchange. And we're also working with our G's and C's people in our government agency to try and make it easier for people to apply for grants and contributions, because as most of us in the room know, it is hard. And even though we try to work with recipients, it's the capacity issues are not going away. So we're trying to change the mindset of some of our other government colleagues who don't probably think as we do, but they have agreed to look at it, which is great. And hopefully we can come up with some solutions, and happy to come back here and present on those when we have them. And then of course, I've just recently met with our Office of Audit and Evaluation to look at doing a proper evaluation of the program. So happy to come back with results in the future on that too. And then if anybody wants any more information, they can take a little screenshot. We have lots of information on all of the different programs and what they do on our website. So that's it.
Thank you very much, Erin. I want to thank all the members of this panel. Are there questions or comments from members of the committee, either in the room or online? Again, I think a lot of it goes back to where you started, Stephanie. It's thinking about both the qualitative and the quantitative aspects of evaluation, but you've got to have the evaluation plan built from the start, and it's got to be a continuous process if we're going to be able to replicate or improve on our status. I'm not seeing any other comments or questions. I want to thank the members of this panel. Stephanie will get you to your other meeting. Our next panel is new approaches for an old and an ongoing threat, tuberculosis vaccine innovation. Our presenters for this panel will be Dr. Jonathan Wortham from the Centers for Disease Control and Prevention, Mike Frick from the Treatment Action Group, Dr. Ann Ginsberg from the Bill and Melinda Gates Foundation, Dr. Maziar Devangai from McGill University Health Center, Dr. Daniel Hoft from St. Louis University, and Lois Priver-Dum from Johns Hopkins University. Dr. Wortham, you have the floor.
Okay. Good afternoon, everyone. Can you all hear me? And I am going to
You're loud and clear.
Okay. And can you see my slides now?
Your slides are up. If you just say next slide, we'll advance them for you.
Excellent. Okay. So next slide. Okay. So we have a couple of objectives and goals here. First, I wanted to review the clinical characteristics of tuberculosis disease. And after doing that, I wanted to discuss the TB epidemiology to serve as the framework for your discussion. We'll discuss the prevalence worldwide and how that relates to prevalence and incidence in the United States. And we'll also discuss some risk factors for TB infection and disease, since I'm aware of a number of TB vaccine studies that have been performed in people with latent TB infection. So we'll discuss what that is and its epidemiology as well. And finally, we'll review M. tuberculosis transmission and pathogenesis as you think about some of the operational aspects in your discussions. Next slide. So first, as I promised, we'll briefly review some clinical aspects of tuberculosis or TB disease. Patients with TB commonly experience symptoms such as cough, often for extended durations for longer than 2 weeks. Some experience fever and weight loss over time. And while cough, fever, and weight loss are common symptoms, TB has been called the great imitator by many clinicians of infectious diseases, and symptoms can be very nonspecific. There are 2 types of tests for infection with the bacteria that causes TB: the TB skin test or the interferon gamma release assay blood tests. Typically, patients with TB have positive test results, but a negative test never, ever, never, ever, ever excludes TB as a diagnostic possibility. Chest radiography is usually abnormal, especially in patients with pulmonary TBs. And currently, TB disease always needs treatment for 4 to 9 months, including at least 3 medicines in the initial regimen. And now for a brief review of global TB epidemiology. WHO, or World Health Organization, estimated that there were more than 10.6 million TB cases during 2022 in the most recent report, or most recent available report. We generally refer to estimates as disease reporting, as disease reporting is not often complete in many places where TB incidence is the highest. 10.6 million TB cases represents an increase from 2021 and 2022 estimates. While TB amongst people living with HIV is a major cause of morbidity, most TB disease, estimated as 85% or more, occurs among people living without HIV. In addition, incidence is not evenly distributed throughout the world. TB incidence and associated morbidity are disproportionately high in some countries and areas of the world relative to others, and among people with certain social, demographic, and medical risk factors relative to others. An estimated 2 billion people, or approximately 1/4 of the global population, is estimated to have latent TB infection, which is asymptomatic M. tuberculosis infection, and we'll discuss this in more detail in the upcoming slides. TB is also a leading cause of death, with an estimated 1.3 million deaths attributed to TB disease worldwide during 2022. Before the onset of the COVID-19 pandemic, TB was often the leading cause of death due to a single infectious agent. In the United States, incidence rates are relatively low compared with most countries. This graph shows the annual number of TB cases in the United States for each year during 1982 through 2002, and the TB elimination threshold goal of less than 1 case per 1 million population, which for the United States is approximately 330 cases per year. In 1992, 26,673 cases were reported in the United States, with an annual incidence rate of 10.4 cases per 100,000 people. TB cases and incidence rates have declined substantially since 1992, but the annual rate of decline was inadequate to achieve TB elimination goals. In 2022, though, just over 8,300 TB cases were reported, with an incidence of 2.5 cases per 100,000, representing a 6% increase in case count and a 5.5% increase in incidence compared to 2021. And in the most recent year, 2023, CDC provisionally reported more than 9,000 cases, an increase of more than 15% since 2022. Development of the annual report summarizing this 2023 data is underway. Next slide. In this slide and the next few slides, We'll focus on 2022 TB epidemiology. Similar to global epidemiology, TB incidence in the United States varies by geography. This map shows each state shaded based on two scales, one representing TB case counts that gets to the darker green, and the other representing incidence rates getting to the darker reds and purples. Case counts reflect the overall burden of testing, treatment, and preventing TB in each jurisdiction, but the incidence provides a clearer picture of the epidemiologic risk by jurisdiction. The lighter shades represent low values, and the darker shades represent higher values on each measure. And in typical years, 50% or more TB cases are reported in 5 or 6 states. Next slide. Similar to global TB epidemiology, there are individual risk factors for TB disease in the United States. And this slide depicts one of the major ones. TB disease disproportionately occurs among people born outside the United States. During 2022, almost 2/3 of cases occurred among non-US born people. The TB incidence rate among non-US born people of 13 per 100,000 people was 17 times the rate of 0.8 per 100,000 among US born persons. Most of these cases occurring in non-US born people are thought to represent progression of infections initially acquired some years earlier. And we'll be reviewing evidence to support that as we go along in our discussion. Next slide. This slide shows the percentage of TB cases among non-US born by number of years since initial arrival in the United States at diagnosis. In 2022, approximately 30%, next slide. 30% of non-US born people with TB were diagnosed within 5 years arrival in the United States, with more than half of those occurring within the first year after arrival. Next slide. And then over 1/3 were diagnosed after being in the United States for at least 20 years. Next slide. This graphic depicts the percentage of TB cases by site of disease during 2022. As is typical, most TB cases were pulmonary only. Another 11% had pulmonary and extrapulmonary involvement, and approximately 19% had solely extrapulmonary disease. Pulmonary disease is often contagious, and the BCG vaccine, one of the more common vaccines in use worldwide, is not thought to prevent pulmonary disease, the most common site of disease among patients diagnosed in the United States, but is thought to be effective against more severe disseminated forms of TB, particularly in younger children. Next slide. So to understand this TB epidemiology in context, we'll consider M. tuberculosis transmission and pathogenesis for just a minute. When a person with TB disease is exposed to another person, often termed a contact by public health programs, next slide, approximately 20 to 30% of those exposed contacts can be expected to acquire M. tuberculosis infection. People in this circumstance are said to have latent TB infection in the United States, TB infection in some other publications, or inactive TB is also another term that's used for this clinical entity. People with LTBI have no symptoms, usually have positive tests for TB infection and normal chest radiographs. Next slide. A brief discussion of LTBI might be helpful review, since at least one vaccine trial was conducted amongst people with LTBI. The prevalence of LTBI was last assessed by CDC during the National Health and Nutrition Examination Survey, or NHANES, conducted between 2011 and 2012. After analyzing data from the survey, CDC estimated that approximately 13 million people in the United States have LTBI, reflecting an overall prevalence of 1 in 20, or 5%. Additionally, non-US born people were more likely to have positive tests for M. tuberculosis infection and therefore presumptively LTBI. Next slide. So among the non-US born, the TST positivity rate was 20.5% compared to an IGRA or interferon gamma release assay positivity rate of 15.9%. These numbers suggest that more than 1 in 8 non-US born people are infected with M. tuberculosis. However, people with certain demographic, social, and medical risk factors had higher prevalence compared with the overall rates. Among US-born people, TST positivity and IGRA positivity rates were quite a bit lower. However, similar to non-US born people, people with certain demographic, social, and medical risk factors had higher incident or higher prevalence compared to the overall. For example, some studies have documented high prevalence among people with certain social risk factors such as incarceration and medical risk factors such as HIV infection compared to overall US born and non-US born prevalence rates. Next slide. Though the overall prevalence of M. tuberculosis infection, as evidenced by a positive IGRA, is 15.9% among non-US born persons overall, there are some important differences by age. Among people 45 to 64-year-old, the prevalence of a positive IGRA was estimated to be 23.5%, or almost 1 in 4. And among people over 65, the prevalence was 32.1%, or almost 1 in 3. And again, to a reminder from our previous discussion, without treatment, 10% of these people with M. tuberculosis infection, or LTBI, will develop TB disease during their lifetimes. Next slide. And these are sort of inform these screening for latent TB infection U.S. Preventive Services Task Force recommendation. And so they recommend screening and testing people for TB infection and TB disease who were born in or former residents of countries with increased tuberculosis prevalence due to some of the epidemiology we've discussed. But they also recommend screening and testing people who lived in high-risk congregate settings, such as homeless overnight facilities and correctional facilities. And they also have a provision that I want to highlight, that certain other groups should be tested dependent on local demographic patterns. And so even though the overall prevalence of TB in the United States is low, there are some groups at risk, and many of those groups, such as homeless overnight facilities and correctional facilities, are known from the US epidemiology, but every local and state program, TB program, might need to reassess their epidemiology and define their high-risk groups. Next slide. And so a few summaries and conclusions before I leave this. TB can be very challenging to diagnose. That is challenged by certain non-specific clinical presentations and very imperfect diagnostic tests at the current time. Nonetheless, TB disease is extremely common worldwide, with more than 1 in 4 people worldwide infected with M. tuberculosis, and it's one of the most common infectious causes of mortality. However, in the United States, overall incidence is lower, and most cases occur in non-US born people. But there is a relatively high incidence in some US born people with medical and social risk factors. Next slide. And there are some real challenges to preventing TB. There is a large group of asymptomatic people who can progress to being contagious and transmitting. This is different than many of the other, this is challenging compared to some of the other diseases that have been eradicated. This asymptomatic clinical entity with a certain percentage progressing to contagious disease. There are also diagnostic difficulties and relatively long treatment regimens compared to many other diseases. Nonetheless, eliminating TB remains a worthwhile goal, and preventing TB-associated morbidity could have a substantial impact both in the United States and worldwide. And stopping transmission within communities could certainly be an asset to reducing infectious disease associated morbidity both worldwide and in the U.S. Thank you for the attention, and next slide, I'll thank you for the attention, and I can turn it back over to y'all.
Thank you, Jonathan. Our next presenter is Mike Frick from the Treatment Action Group.
All right. Hi, good afternoon. I'm Mike Frick with Treatment Action Group. We're a research and policy think tank advocating for research addressing tuberculosis, HIV, viral hepatitis. It's great to have this opportunity to talk to you about the TB vaccine pipeline, show you some of the candidates that are under active development. And before I get there, I want to tell you where my information today is coming from. There are three main sources of information on the TB vaccine pipeline. The one that I'm involved with is Treatment Action Group's annual review of TB vaccines under clinical development, which we publish in our pipeline report series. The Working Group on New TB Vaccines, which is hosted by the Stop TB Partnership in Geneva, Switzerland, maintains an excellent pipeline web resource, and the World Health Organization publishes a summary of pipeline information in its Global TB report each year. And very happily, all three of these initiatives work together so that we can provide a consistent, impartial view of TB vaccine development that is based on direct outreach to sponsors and developers, clinical trial registry information, and other publicly available data. Before getting to the pipeline and some of the specific candidates, I want to put it in the larger context of preventing TB. New TB vaccines are being developed, and they will be introduced alongside other prevention tools. We have preventive treatment for tuberculosis, which is as short as taking 28 days of preventive therapy, and work is underway to develop long-acting forms of preventive treatment that could be given in 1 or 2 doses. We also have a vaccine for TB that was alluded to in the previous presentation. It's called BCG. It's over a century old, and it's given to infants in many countries to protect against severe forms of TB in childhood, but offers very limited protection against pulmonary TB in adolescents and adults, where most disease resides and where most transmission occurs. Adequate nutrition is very important, as is management of comorbidities such as HIV. So we have no silver bullets, but lots of powerful tools, and hopefully a new TB vaccine will give us an additional tool for preventing TB in the near future. I want to show you some of the types of vaccines that are under development. Currently, the pipeline has all of these different types represented with specific candidates. There are viral vectored vaccines, subunit protein adjuvant vaccines, and mycobacterial vaccines, which include both killed whole cell vaccines as well as live recombinant or live attenuated vaccines. And just recently, the first TB vaccine constructs based on mRNA entered phase 1 testing. But I think it's important to point out that even though we have some diversity in vaccine type and platform, it doesn't necessarily imply a diversity in antigen presentation. And selecting the right antigens to target with vaccination from MTB's very large genome is a vexing scientific challenge that continues to be a major obstacle for TB vaccinology, one that I'm sure my other panelists will have more to say about. So the vaccines that are in the pipeline are being pursued by and studied by developers sort of under 3 overarching strategies, which are known by the primary endpoint of interest for the studies. The primary strategy is developing vaccines for prevention of TB disease, usually measured as preventing microbiologically confirmed pulmonary TB disease, and those are called POD studies. There also is some work underway to develop vaccines for prevention of infection, as well as for prevention of recurrence. And in the case of POR, or prevention of recurrence, these vaccines would be given to people who have already had TB disease, received treatment to lower their risk of getting TB again. And that recurrence could be defined as either relapse or reinfection with a new strain of TB. But prevention of disease is really considered the dominant strategy, the one that's most likely to result in licensure by regulators because the endpoint is most precisely defined, and the strategy that would have the most individual and public health benefit and impact. So this is the pipeline, a kind of bird's eye view of it, and I'll show you what it looks like on the next slide. There are currently 15 vaccine candidates that are under active clinical development, including 5 that are in or preparing to begin phase 3 clinical trials. These phase 3 and phase 2b studies will together enroll more than 80,000 people, which I point out here just to say that this is the most people participating in TB vaccine research at any single time since the middle of the 20th century, when India ran several very, very large studies of the BCG vaccine. And this is a truly global endeavor taking place on all continents. And most importantly, I think these clinical trials are giving us the opportunity to collect data in humans. And the samples that we collect in biobank will fuel basic science, discovery, and translational work to repopulate the pipeline, generate new candidates. And they will also give us the opportunity to test our candidates in diverse populations at risk of TB. So some studies are including people living with HIV, others are targeting children, some are enrolling what we call household contacts, people exposed to TB at home. So here I'm showing you the pipeline, these candidates, the 15 that I mentioned earlier. Their names are represented in bold. I've organized them by phase of the most advanced clinical trial that they've entered or are preparing to begin. And the color coding is telling you the vaccine type. So as you take in this slide, I want to point out a couple of things. The first is that it's a bit inverted from what we might expect for a typical clinical development pipeline, where you would expect to see a lot of candidates in phase 1 and attrition as you go to phase 3. But our pipeline at the moment is a bit top heavy. There's more in phase 2b and phase 3 than there is in phase 1. So it's really important that we continue preclinical and discovery work to keep the pipeline populated. Among those candidates in the late stages, you can see that subunit vaccines in green and whole cell mycobacterial vaccines in orange and red are well represented. Then in phase 1 in blue are the first mRNA TB vaccine constructs that have started phase 1 trials. Those were developed by BioNTech. The last thing I'll say here is that the two candidates with the gray overlay are those for which work has recently stopped. In the case of that H56 candidate in phase 2b, based on negative results from a prevention of recurrence trial that were released in December 2023. So this is a view of that same pipeline. I'm just drawing your attention to a couple of notable developments that I think the committee might be interested in. In the following slides, I'm going to focus on two candidates in phase 3, MTBVAC and M72 AS01E. But before I get there, I'll just call your attention to the top two candidates listed in phase 3, two whole cell mycobacterial vaccines called MIP and VPM1002. These two vaccines are in a phase 3 clinical trial being run by the Indian Council of Medical Research, each compared to placebo. It's a 3-arm study. It's enrolling household contacts, people exposed to TB disease in the home, and it's fully enrolled, data is in hand, and we understand that results are expected sometime this year, so potentially very soon. In phase 1 then are those first mRNA candidates, but there's also a new subunit vaccine, H107, with the CAF10B adjuvant. So phase 1 does have activity, it's just a little sparsely populated. So now I want to take a closer look at M72 AS01E. This is a subunit vaccine that combines two MTB antigens with the AS01E adjuvant proprietary to GSK, and also in the licensed Shingrix and RTSS vaccines for malaria. This candidate has generated a lot of excitement and enthusiasm. It was initially developed by GSK, and work is now being taken forward by the Gates Medical Research Institute, which has started a phase 3 trial of this candidate, meant to confirm a positive efficacy signal in a phase 2b trial that was conducted in Kenya, South Africa, and Zambia. That study published final results in 2019, and I'm showing you a summary of those results from the paper in the New England Journal of Medicine here. It enrolled over 3,000 adults. They were HIV negative, and they entered the study with a positive test for TB infection. So they were IGRA positive. And at 3 years of follow-up against a primary endpoint of definite pulmonary TB disease, there were 13 cases of TB among those randomized to receive M72 compared to 26 TB cases in the placebo group, working out to an estimated vaccine efficacy of just under 50%. And it's the strength of that result, which just barely met the WHO's definition for sort of a minimum efficacy required to take a further interest in a TB vaccine, that the Gates Medical Research Institute is now pursuing a phase 3 trial. I'll show you the trial design on the next slide so you can get a flavor of what it's focusing on, but they did a lot of preparatory work before opening that study, including looking at M72 in people living with HIV, demonstrating safety and good immunogenicity, allowing people with HIV to enroll in the phase 3 trial. And they also prepared by doing a very large epidemiological study, which was meant to prepare potential trial sites by getting local estimates of TB infection test positivity and TB incidence. And that has enrolled 8,000 people across the world. So here is a summary of the M72 phase 3 trial design. This is a very large study by the standards of our TB vaccine field. It will enroll 20,000 participants into 3 different cohorts. The primary efficacy analysis and the bulk of participants will be in the first cohort that's listed there. 18,000 participants will enter the study with a negative HIV test, but a positive test for TB infection, indicating they have latent TB or at least sensitized to Mycobacterium tuberculosis. And the primary analysis will evaluate vaccine efficacy for the prevention of bacteriologically confirmed pulmonary TB disease among that group. There also is a cohort of people who are HIV negative, IGRA negative, meaning they don't have a positive test for TB infection, and about 1,000 people living with HIV will enroll as well. The study is enrolling in 7 countries in Africa and Asia. It's funded by Gates Foundation and the Wellcome Trust. Enrollment opened this March, and I understand is proceeding very briskly, which is great news for a TB prevention study. The Gates MRI estimates that they could have results 4 to 5 years after enrollment opens. So that puts us on a timeline of about 2028 to get a primary readout from this study. The other candidate I want to draw your attention to is MTB-VAC. It's a very interesting candidate because it's a live attenuated mycobacterial vaccine. It's actually based on a clinical isolate of Mycobacterium tuberculosis itself. So it is the organism. It's been attenuated by the deletion of 2 genes coding for 2 major virulence factors, was initially developed in Spain and is now being taken forward by a Spanish biotech company called BioFabri. MTB-VAC is interesting because it's being studied in both infants in a phase 3 trial, as well as a study that is in planning for adolescents and adults. So here's a look quickly at the MTB-VAC infant trial. 7,000 infants will be randomized to either receive MTB-VAC or BCG. So the comparator here is not placebo, it's that BCG vaccine. The primary outcome is looking at TB disease. And this study is currently enrolling in 3 countries in Africa. And then I wanted to give you a quick look at the other MTB-VAC efficacy trial. This will be a phase 2b study, also to be conducted in Africa. About 4,300 participants will be randomized. The study hasn't opened yet, but it is registered with HHS.gov. In many ways, the design is very similar to the M72 phase 3 trial. The primary efficacy analysis will look at prevention of TB disease among participants who enter the study with a positive test for TB infection. And it's likely that enrollment will eventually open to include people living with HIV, pending supportive data from a phase 2 study of this candidate in that population, which is currently being run and sponsored by NIAID with the HIV Vaccine Trials Network and the AIDS Clinical Trials Group. Before ending, I just want to take us back to the start of the pipeline and talk about mRNA for a minute. I mentioned BioNTech has 2 candidates, each constructed of about 8 MTB antigens that have entered phase 1 testing. And they're doing 2 studies of these 2 candidates, one in Germany and one in South Africa. But there's a lot of preclinical activity on mRNA TB vaccines. IAVI Moderna have a partnership in this regard. The WHO's mRNA Technology Transfer Hub at Afrigen and the South African Medical Research Council has started preclinical work on mRNA TB vaccines, and work is also underway at Akagera Medicines out of Rwanda, Curatis in South Korea, and PopVax in India. So we expect many more mRNA constructs to enter the pipeline in the coming years. And then my last slide is just a note to say, and I have to say this, that the science is really promising, but the resources are extremely lacking. So in addition to tracking the pipeline, Treatment Action Group does an annual survey of how much money is spent on TB research in a given year. I'm showing you the funding numbers for expenditures on TB vaccine research in fiscal year 2022. Globally, all funders combined, governments, philanthropies, pharma, spent only $145 million on TB vaccine research in 2022. I think the only word for that is really pitiful for a disease that causes 1.3 million deaths a year and makes over 11 million people fall ill. And if we want to deliver on the promise of the pipeline, we really need to increase funding in this area. So with that, I'll just say thanks, and I'll offer some acknowledgments for the people who helped me track the pipeline. Thank you.
Thank you very much, Mike. Our next presenter is Dr. Ann Ginsberg from the Bill and Melinda Gates Foundation.
Thanks very much. It's really a pleasure. Can you all hear me?
You are loud and clear, Ann.
All right, then let me come on screen as well. Oh, the host has apparently stopped my video. So, okay.
She's working on it, Ann.
I got a notice. Just
There you
there.
are. Yeah.
Terrific. It's a pleasure to be with you all and have this opportunity to further share with you some of the excitement and progress in TB vaccine research and development. I've been asked by the committee to focus in particular on areas and mechanisms of collaboration in the field and some of the challenges that the collaborators, of whom there are many, as you'll see, are trying to address. So if you could go to the next slide, please. Let me just say at the top here, I've provided a diagram of what we often refer to as end-to-end vaccine development. That is all the work that needs to take place from discovery on the very left, all the way out through registration of new vaccines. And then the other half of a very large body of work needs to take place as well. That is ensuring there's adequate financing, people and organizations to procure and to introduce, and ultimately manufacturers to provide a sustainable supply of any worthy new TB vaccine. And of course, as a result of all these activities that need to take place, we need to be thinking about vaccine development in an end-to-end way. And there are many, many stakeholders involved, from early stage researchers out through implementers. And committees such as this one also play an important role in influencing both country and regional decision-making, policy-making, preparation for vaccine introduction, et cetera. On the next slide, I've just provided an example of some of the very active stakeholders and which stages of this end-to-end development they're currently involved in. Many of the organizations you see here are involved in multiple stages. So this is a great simplification, and it's only a small selection of the key stakeholders. And in the interest of time, we won't go through that in detail, but just to give you some idea of the players in the field. On the next slide, I've chosen just 3 of what I see as major collaborative initiatives in the field that address different aspects or different phases of this end-to-end continuum. And on the following slides, I'll just tell you a little bit about each of these and perhaps relevance or interest to NVAC. So on the next slide, please. We'll start with the collaboration for TB vaccine discovery. In full disclosure, CTVD was founded before my time at the Gates Foundation, but by the Gates Foundation in 2015. And it now includes over 375 members from 86 different institutions worldwide. And it's intended to be a network of scientists, experts who will come together to, in a collaborative fashion, foster innovation and cooperation. And it started really pretty much entirely focused on sort of the upstream TB vaccine discovery space, but has expanded over the years as the field has advanced into translational research and some product development as well. And it really is sort of the key driver of our vaccine strategy at the foundation, which goes from trying to accelerate discovery, advance both the most promising preclinical and clinical stage candidates, and create and support implementation of new improved tools to help the whole field accelerate to effective, accessible new TB vaccines. And so collaboration that's driven by this organization through both small research communities or working groups and a large annual meeting, amongst other activities, is really key. And I just wanted to say, if any NVAC members are interested in learning more about the organization and seeing how they might contribute, to please just reach out to me. I've provided my email here, as well as CTVD's website is listed there in the lower right-hand corner of the slide. Next slide, please. So some of the gaps that have been identified, not just by CTVD, I think these are pretty obvious to anybody who's been working in this field. And if you could advance one more time, we'll also show you some of the just examples of projects that CTVD members are working on to try to accelerate progress against these key gaps. Some of them you've already heard about. We don't really understand the full list of protective antigens that should be included in TB vaccine candidates. We don't have a predictive, validated animal model with which to test these candidates and give us confidence that a particular construct will be protective in humans until we test it in humans. We don't have full understanding of the human protective immune response, though a lot of progress has been made over the years in this area, and we certainly know a lot more than we used to, but not enough to have yet identified and been able to validate a vaccine-induced correlative protection. So we don't have anything like antibody titers that we can measure in vaccinated individuals and say, okay, that person's going to be protected or is likely to be protected. And as Mike explained, we need a much more robust pipeline of next generation candidates. Next slide, please. So the next group I want to tell you about, Michael also mentioned, because they put out a pipeline report as well in collaboration with both TAG and the WHO. And this is the Stop TB Partnership Working Group on New Vaccines. This is a longer established group, having been founded in 2001 by the Stop TB Partnership. And it's an informal network of stakeholders who are engaged in all aspects of TB vaccine research and development across a broad range of constituencies. And membership is really open to anyone interested in being engaged and involved in TB vaccine research and development. So if this is an area of interest to you, I encourage you to either go up on their website, which again is in the lower right-hand corner, or there's a hot link there by the word membership, which will take you right to the membership form that you can fill out. And this group focuses to a large extent on providing sort of an inclusive forum for this broad group of stakeholders to engage both in scientific exchange, but also to build consensus on key issues in the field. And very importantly, to come together to advocate for greater support and investment in TB vaccine research and development. Next slide, please. And the last group I wanted to just make you aware of is a relatively newly formed group, having been announced by the WHO in 2023, and is under the aegis of the Director General of the WHO and run out of the office of its Chief Scientific Officer, Jeremy Farrar, who many of you may be familiar with. And this has been established now that there are late-stage candidates as an informal and voluntary group of mainly very high-level people to enhance both the technical and political cooperation that's going to be needed to really effectively adopt implement and sustainably supply new effective TB vaccines. And so it's composed of a high-level ministerial board comprised mainly of ministers of health and finance, both from countries in the global north, but primarily from high-burden TB countries. And then some of their support staff at also very high-level individuals. And then they are in the process of getting ready to announce, or not yet announce even, begin to establish technical and strategic working groups who will help address the many challenges involved in getting vaccines once licensed out to implementation to the populations who really need them, and who will report into the principal group and the ministerial board as they make progress in addressing the challenges, which I will show you on the next slide, I believe. So this is a very high-level view of some of the challenges that the WHO Accelerator Council and its many members and ultimately its working groups hope to address. It's a landscape and gap analysis that was commissioned by the WHO and conducted by the Boston Consulting Group in the last year to 2 years. And it really focuses on that right-hand end of the development continuum that I showed you at the beginning. And the bright colors show you where in that, in the many stages of really implementing and delivering new TB vaccines, there are important gaps, and they're also laid out across the bottom. So there are major deficiencies in global coordination and consensus, because this is, in a sense, such a young field. It's only very recently that there have been late-stage candidates with robust data behind them that people feel are likely not only to get licensed, but to be able to meet the preferred product characteristics and really have impact. There's clearly a need for some creative financing and real innovation in how these vaccines will be supported for the many lower and middle income countries, many of whom have graduated from Gavi, but yet are very high burden TB settings. Manufacturing still needs to be addressed for some of these vaccines, particularly, again, sort of regional manufacturing that will ensure equitable access. There's a real dearth of awareness and alignment outside of the TB vaccine community. So I certainly commend this group for asking for this panel to come and give them an update on what's happening in the field. But there are many other important groups who one would hope would be aware of the progress being made in TB vaccines, as well as just the need and what kinds of vaccines are needed, who are really still very much in need of that kind of education. And then there's very little country-specific data in the high TB burden countries that those countries are going to need and want in order to make decisions on which, if any, of these vaccines to adopt, how they're going to finance them, and very importantly, how they're going to implement them, particularly the adolescent and adult vaccines, which, as has been explained, are really the highest priority, because those are the ones that will stop transmission from adolescents and adults with pulmonary TB and will have the biggest impact on the epidemic, thereby really protecting all age groups. And as you all know as well as I do, that there are very few countries in the world, including this one, who have even a reasonable infrastructure to deliver adolescent adult vaccines. So there's a lot of work that needs to be done both on a country level and on a broader global level to ensure delivery and health systems readiness and engagement of the health systems in the countries who can best benefit from TB vaccines. Next slide, please. And so here again, I just wanted to make sure you all were aware and had easy access to many of the resources that are now available and have been published in recent years by WHO and other key organizations, and they range from the pipeline reports that Mike told you about to WHO's preferred product characteristics for TB vaccines, a global roadmap of R&D, an investment case for a new TB vaccine, and you'll hear about that in a bit from the last panelist, a global framework to help countries prepare for introduction, also published by the WHO, as well as the WHO's evidence considerations for vaccine policy development for adolescent and adult TB vaccines. And finally, a recent example of a market analysis that was conducted with funding from the Wellcome Trust and recently published by them of what an M72 AS01 like vaccine market might look like. I think that's my last slide. Go to the next. This is a favorite African proverb around the Gates Foundation, and I thought was particularly apt for this discussion of collaboration, which is, if you want to go fast, go alone. If you want to go far, go together. So thank you for your interest.
Thank you very much, Anne.
Produced by the U.S. Department of Health and Human Services.